As a psychiatrist, I've heard other clinicians describe patients with borderline personality disorder as attention-seeking, manipulative, overly dramatic, even terrible patients. And I think that's tragic. And those comments speak not to the condition, but to the many still prevalent misconceptions about it. And to be clear, I think those misconceptions are becoming less and less common. They're still there. And on some level, I also understand why they've come about. Because from the outside, borderline personality disorder can look dramatic, intense, even overwhelming, even for the clinicians. But that also speaks to the intensely painful nature of this condition for the people who suffer from it. So today I want to go over what BPD is, borderline personality disorder, why it's so often misunderstood, and try my best to convey what this condition feels like for the people who live with it. And to do that, I'll share with you a case from my own training. And for those of you new to the channel, welcome. I'm Dr. Robert. I'm a board-certified psychiatrist. And on this channel, I enjoy making mental health videos. And as always, these are for educational purposes only, not medical advice. And if you are experiencing any mental health symptoms, please seek the care of a local mental health provider. Let's jump straight into that case of BPD from my training that I want to share with you, that I think really exemplifies what BPD looks like, how it can feel, how it can cause a lot of distress in clinicians, and how it can improve. And of course, all patient details have been drastically changed to protect patient identity. So I was early on in my residency training. It was 1 a.m. and I got paged, as always happened at 1 a.m. as soon as I was starting to fall asleep. And it was to evaluate a student that had been brought into the emergency room after a suicide attempt. And as I was walking towards the patient's room, still waiting for the sugar from the Rice Krispie to fully kick in, a nurse passed me and she said, kind of dismissively, just another borderline. And that certainly wasn't the first or last time I heard someone be so dismissive towards someone with BPD. So I walk into the room and there's Jenna sitting on her hospital bed, dressed in a hospital gown, IV running into her arm, and she does not look pleased to see me. Instantly she asks, "Can I leave yet? Can I get out of here?" Now, in the walk over, I reviewed her chart and noticed that she'd had a pretty serious Tylenol overdose, which is what brought her in. So I was definitely caught off guard by her instant request to leave. As though nothing serious had just happened and this isn't an inconvenience. So I let her know, not yet. Let's first talk about what happened. I introduced myself and I invited her to tell me, fill me in on the details. What was going on that led to the overdose? And at first she rolled her eyes, was kind of dismissive, but then she started to open up and told me the story of what happened. Basically, earlier that night, she'd learned that her friends had gone out without her. They didn't invite her to come along. And when she confronted them about this when they came back, they said that she was too much drama. They didn't want to bring her out. They were afraid something crazy would happen, as often happened when she went out with them. So chief complaint, too much drama. And so then, being a good shrink in training, I asked her, well, how did that make you feel? And then she kind of paused and thought for a moment. And I could see that she was kind of struggling to articulate exactly what she was feeling. And I'll get to that later because that can be a struggle within BPD, is actually articulating and labeling emotions, especially when they're heightened in the moment. But now her emotions were much less heightened. She was calm and experiencing less distress. So she was able to kind of think about it some more and start to speak to it. She filled me in on how she just felt so overwhelmed. She just felt like all this energy, this tension was in her body when she learned that. There was this intense sense of rejection, of fear that, her friends don't like her anymore. She's flawed. She's not worthy of time being spent with her, of friendship. And that really, really felt painful. So painful that she didn't have any other way that she thought she could handle it other than to end things right then and there. And so she went into her dorm, took a lot of Tylenol, drank it down with alcohol, and when she started to get nauseous and vomiting, then she let her roommates know what happened. And of course, they called 911, and she was brought into the hospital. And luckily for Jenna, everything was caught in time. She would be okay. But of course, oftentimes it also isn't in these types of situations. It can be very dangerous. As a side note, I think some of the most tragic cases I'd seen in all of my training were when people did overdose on Tylenol and then it was too late by the time they came to the hospital. Nothing can be done and they were sort of left in limbo, just sort of waiting out their life and maybe hoping they get a liver from a potential liver transplant, which is never guaranteed. Very tough, very tough. And then Jenna told me something that really stuck with me. She said, "I don't know why I did it." Looking back at it, she regretted it. She didn't want to do it, but she just said in the moment, she felt like she didn't have a choice. It was the only way she could manage to relieve the tension, the anxiety, the fear, the self-hatred in that moment. She said to me, "I felt like there was nothing else I could do." And over the next several years, I would actually get to know Jenna quite well. That was not her last time in the emergency department for such an incident. She would come back several more times, and it was always followed after some sort of self-harm, an attempt on her life that always happened after a sense of rejection. Whether that be conflict with her friends, someone ending a romantic relationship with her, a conflict with her family. There's always some sort of interpersonal conflict that triggered this. And I can understand, right? Because on the surface level, this is attention seeking, right? I can see where that comes from, because it is, right? It gets people's attention very quickly when someone does something drastic to harm themselves. And I can also understand how people in her life view this as manipulation, right? Basically, don't do me harm, constantly like me, give me reassurance, or else I'm gonna do something to harm myself and it'll be your fault. And of course, this behavior is very scary for her family, her friends, her mental health care providers as well. That's not something easy that we sit with when we have patients who act in these ways. But it's very helpful to understand why this is happening, because that's just the surface level of the behaviors and the effects they have on others. So let's take a look at what's really going on in BPD. It can be very helpful to look at the behaviors in BPD as normal psychological responses turned up to extreme. One of the core features of BPD is fear of abandonment. That can trigger intense, overwhelming emotions. And that can lead to intense, drastic, impulsive behaviors. Then what we see is self-harm, acting out. These are ways to try to manage that, ways to try to act on those intense internal reactions. And at the core of most cases of BPD is this intense fear of abandonment. It's a person just really wanting to connect and then really struggling when that doesn't happen, which is a very understandable, natural human instinct. And I think all of us can have empathy for that. And those are some of the key features of BPD. Before I continue with the psychological underpinnings of BPD, let's go back to the trajectory of what happened with Jenna next. Because she would at times be psychiatrically hospitalized, sometimes discharged, depending on the circumstances. But oftentimes the psychiatric hospitalization, it wasn't actually very helpful. It can be very helpful for people in states of mania, psychosis, or who have suicidality as a result of depression and are unsafe and need stabilization, need to be plugged in with care. But oftentimes, not always, but oftentimes with BPD, the crisis is over by the time they're in the hospital. So they're already usually safe enough to go home and there isn't that much of an elevated risk, of course with some nuances and every circumstance is different, but oftentimes that is the case. And so sometimes psychiatric hospitalization can further destabilize people because it kind of confines them, it puts on more stressors, that triggers more of their defenses, more of their fear of abandonment, or sometimes even reinforces their need for attachments with staff in the hospital. So sometimes there are cases of BPD where people recurrently come into the hospital almost because they've learned that they do get some nurturing there. And other dynamics can come up that I won't fully get into, at least in this video. But the core idea I'm trying to get to here is people like Jenna, people with BPD, they don't need help after the crisis. They need help for how to regulate their emotions leading up to the crisis and between crises and what to do in the moment. I think a common question I get from many people is, how did people develop this condition in the first place? How does extreme behavior like this come about in people's lives? Where does it come from? Well, as I got to know Jenna over the years and got to speak with her more, she filled me in on her background. And of course, everybody's case of BPD is different. There are genetic, environmental factors that contribute to it. But she told me how, growing up, her mother also likely struggled with undiagnosed BPD. She also had a lot of really intense mood swings that could swing multiple times in a day, strong emotional reactions. And then as Jenna was growing up, whenever she demonstrated any independence, broke away from mom in ways that angered mom, she would be met with very severe reactions, and that would trigger further fear of abandonment in Jenna, reinforce some of her extreme coping mechanisms. And the more her mom tried to double down on punishment, the more Jenna would rebel, and this kind of intense cycle of emotional reactions, escalating fights would kind of continue, and to some degree sort of propagate both of their BPD symptoms. So in this case in particular, we have a genetic predisposition, and there are a lot of studies, just to be clear, that do show that there is a genetic component to BPD, and there's also an environmental component. So a lot of interpersonal conflicts, trauma, sexual trauma, physical, emotional trauma, neglect, all of that can kind of propagate, reinforce, and amplify symptoms of BPD. Another clear thing, BPD is a personality disorder, and by definition, someone has to be over the age of 18 to meet criteria for a condition like this. You can't diagnose it in kids, just to be clear. But like many people with BPD, Jenna was a very bright, very ambitious person. She actually excelled in school. She got into a very good college, had a promising path ahead of her. She was able to make good friends, relationships, although sometimes they would be rocky, wouldn't last long, but she was able to do those things. So she had a lot of strengths. And most importantly, she wanted to get better. She did not want to feel like this. She was very distressed, very ashamed of of how she experienced this emotional turmoil and the way she reacted to it. So how could we help Jenna? How could we help her live a life more in line with her values? Well, one of the great privileges of my training and residency was I got to work with some really renowned experts in various fields. And one of them was actually a renowned national expert in BPD and personality disorders in general. So I got to work with him very closely over the course of several years, and he taught me a lot. And here are some tidbits of knowledge from him. He taught me a lot about DBT and other therapy modalities, where basically you help people learn to tolerate distress. You help build up and fortify some of their interpersonal skills. You help them reduce some black and white thinking. You also allow them to process their prior trauma, to sit with the stress when it occurs, find other ways of addressing it other than turning in on yourself. As anyone who's in BPD treatment will tell you, it's not a quick process. It's not easy. Nothing gets better in days, weeks, sometimes even months. But if you stick to it for years, or even months, doing DBT training, getting a lot of therapy, working through prior trauma, working on interpersonal connections, these things drastically improve symptoms. Shortly before I graduated residency, Jenna had completed a long course of therapy, had gone to a few outpatient programs as well, and she graduated college. And she was going on to grad school. She was in a stable romantic relationship. She was able to make new friends and hold on to them. She still had some conflicts with mom, and definitely some family tension was still going on, causing some occasional instability. And sure, life was always going to happen and make things tough. But she now had the skills. She had the ability to tolerate the stress and manage it in ways that weren't self-destructive. She actually no longer met BPD criteria by the time she graduated. And that's true for many people with BPD. With ongoing treatment, a few years in, they no longer meet the criteria. They have successfully treated themselves out of the personality disorder. I feel like I'm just touching the surface of BPD here. So definitely let me know if you want more videos on this topic, going over more examples, more ways it can manifest, and some more of the theories behind it and treatments behind it. Thank you so much for sticking around to the end. I really appreciate it. Still a small YouTube channel, so any likes, subscriptions really go a long way. I really appreciate it. And I hope to see you next week. Thank you.